Folks, really excited to speak with our guest today, Dr. Yousuf Zafar. Dr. Zafar is a practicing oncologist. He's also an adjunct professor at Duke University, and he's currently the chief medical officer at AccessHope, which we'll hear more about during this conversation. Prior to this, he was the senior vice president of medical informatics at Optum and Change Health. He is a nationally recognized oncologist, healthcare executive, and population health researcher with over 100 peer-reviewed articles to his name. So what a pleasure. Yousuf, I rarely get to speak to oncologists. I have a lot of colleagues and friends who are orthopedists and primary care and lots of other specialties, but not oncology. So this is really a treat for me to have you on the program and for you to share, in particular, the work that you're doing today.
My pleasure to be here, Zev. Thank you so much for having me. And I really look forward to this conversation because so much is happening in cancer care today that is relevant not just to oncology, but really translates across all of healthcare.
Oh, now you've got me even more excited about this conversation and curious. So quick question before we dive in to a lot of your work right now, and I'm really interested in hearing this sort of ramification to the larger healthcare system. Across the board in quality, we have, over the past quarter of a century, since we thought we were going to cross the quality chasm back in 1999, we have not yet begun to cross that chasm. When you look at the facts, when you look at the stats in terms of hypertension, diabetes, heart disease, these are all huge chronic diseases. For example, hypertension causes over 600 deaths in the US alone, just high blood pressure itself. 50% of Americans have high blood pressure. 80% of it is not controlled. 80%. So we're talking about 4 out of 10 Americans walking around with high blood pressure not controlled, leading to over 600,000 deaths. Heart disease, nearly 1 million deaths a year. And so we have not moved the ball. In fact, when you look at us compared to other countries, we rank down 30, 40, 50, 60. In fact, our health life expectancy, where we rank 40th in the world. When you look at healthy years, we rank 80th in the world, which is just, it's abysmal. It's almost unconscionable. I can't even understand it. I'm not even sure I could explain it. What is the story when it comes to cancer? How have we been doing over the past few years? Are we getting better? Are we staying the same? Are we getting worse? What's your take as an expert in this field?
Cancer is a tale of two statistics. There are two different perspectives that you can take when it comes to answering the question of, how are we doing with cancer? So let's take the good news first, and that's the population level perspective in oncology. And from a population perspective, we're doing better. Many people don't realize that the peak rate of mortality for cancer was back in 1991. And ever since then, fewer and fewer people every year have been dying of cancer. Now, incidence continues to rise, particularly concerningly in a younger population, a younger than 50-year-old population. Mm-hmm. Yet fewer people are, and I think that's a really important point to sort of think about in terms of what's changing with cancer. Mm-hmm. Yet fewer people are dying of cancer. Mm-hmm. And that means people are living longer with cancer. And in many cases, many cancers have sort of turned into this chronic disease when 10 or 20 years ago, somebody with that diagnosis, that particular cancer diagnosis, would have died in months. So from a population level, we are seeing some tremendous progress when it comes to cancer. Now let's look at the other side, the other perspective, the other side of that coin, at the individual story of what's happening with cancer. In that today, if somebody is diagnosed with colorectal cancer, that's advanced, stage 4 or metastatic, right? If they were diagnosed 20 years ago, they might have lived 6 months. Mm-hmm. Today, again, from a population level, you see a tremendous progress there of, well, it's not 6 months. The median survival now maybe is 3 years.
Mhm.
But that's still just 3 years when you think about it from an individual perspective. So we
Mhm.
have so much more work to do when it comes to cancer. And I think it's, important for me and for all of us to sort of be really proud of the accomplishments that we've seen in the past 10 or 20 years and
Mhm.
still say that is not enough. We've got much more
Mhm.
work to do.
So let me see if I can summarize this and see what you think of this summary. So it sounds like we've gotten better at treating cancer, but we've gotten worse in terms of preventing it.
Well, we are definitely have gotten better when it comes to treating cancer. We are, in some sense, helping people live longer, even with less toxicity, because many of the
Mm.
new drugs that are coming out have less of that typical toxicity that you think about with old school chemotherapy.
Mhm.
Um, the challenge that we have that you brought up in your second point is we are now seeing higher rates of cancer incidence in a younger population,
Mm.
a group of patients that weren't typically affected
Mm.
with cancer, again, a couple decades ago. And the why behind that
Yeah.
is fascinating. Why are
Yeah.
people under the age of 50 now more likely than ever before to get colon
Mhm.
cancer or to
Mhm.
get breast cancer? In fact, two studies just this year
Mm.
have now named colorectal cancer as the highest cause of cancer death in a population younger than 50.
Yeah.
And so why is that? Well, I think, the short answer is that is we don't completely know. But very likely the cause behind this change in trajectory for younger populations has to do with diet, has to
Mm.
do with exercise and lack thereof,
Mm.
and a lot of these behavioral factors that are
Mm.
really shaping cancer statistics at a population level now.
That's interesting that you mentioned diet and exercise, essentially lifestyle, uh, in terms of a major potential causative factor for the increasing prevalence of cancers in the younger population, particularly colon cancer.
Mm.
You and I haven't talked about this before, but I have introduced over the past year a Living Well series in this work. I used to focus mostly, in fact, exclusively on the healthcare industry and getting into sort of geeking out with the folks who are listening. Lately, though, by the request of listeners, um, the question was, could you talk about health and not healthcare? And so it's fascinating that you as a scientist and and a researcher and a population health expert in this area go to that causative factor in terms of lifestyle. And in fact, I just had the president, Dr. Padma Patel of the American College of Lifestyle Medicine, just interviewed her and shared that with listeners. What evidence or what makes you say that? And I don't want to spend too much time on this because I really want to get into some of this stuff. But I'm actually, it's interesting that you actually said that. I wasn't aware that that was necessarily the reason that younger people in this country are getting that. Is it that we're seeing worsening diet, worsening, lack of exercise, lack of attention to lifestyle, and in what ways?
Yeah, I mean, and that's why I started my answer by saying, well, the short answer is we don't know, but we
Mm.
think this is what it is, and it has to do with exactly what you just said, right? That we are seeing a trend towards decreased activity levels and decreased exercise in this population. We are seeing a trend towards increased obesity and improper weight management in this population, and of course, we know the issue around ultra processed foods and how it's sort of just taken a hold of this country and our daily diet. So
Mm.
the at least the circumstantial evidence at this point is pointing towards these factors as the cause for this trend. We just don't know definitively yet.
Let's switch over to your focus, which I actually think is so important. And I am still very curious about your issue of the larger picture of healthcare, not just in oncology. So you in your work have been focused on the gap in cancer care. So we have, increasingly better and better treatments that allow people to live longer with cancer, but it's not getting to everyone. So I'll just, please take it from there.
Yeah. I spent 14 years of my career um, in a room with a patient, patients with cancer and their family. And,
Mm,
when you're in that quiet room, you can hold a patient's hand, you can make eye contact with them, you can talk them through the hardest decisions that they're ever going to make, and you can impact their outcome. The- I'm biased, but I feel like there's really nothing more
mm,
rewarding than to be with somebody like that, to help someone like that in their moment of greatest need. Over that course of my career, I started thinking, this is so unique, and yet it's something that is so needed. And how can we find a way to take that the kind of attention that you get one-on-one between a doctor and a physician and a patient? How can you take that focus and really apply the benefits of that relationship across a population? And that's really what I wanted to think about, this idea of democratizing cancer care, where we know that there are pockets of outstanding care throughout the country. But that care is not necessarily getting to every patient who needs it. And there has to be a way to do that. And I really
mm.
wanted to think about how can you scale that one-on-one relationship to the level of a population.
So there are pockets. I'm wondering what is how big an issue or how big a problem is this? Like, what percentage of the country do you think is not gaining the access to the care that you're talking about? And is there a difference in the different types of care, for instance, going to certain centers versus others?
Yeah, so I think there are a couple of statistics that might help answer that question. So let's first define, okay, if we were to say where are the pockets of excellence, right?
Hmm.
I
Hmm.
think, most people would point to the National Cancer Institute designated comprehensive cancer centers around the country. So these are the academic centers, the big names that, we are all familiar with when it comes to where the best cancer care, the most cutting edge cancer care is delivered. Now, the challenge is only 20% of cancer patients in this country receive their care at these centers, which means everybody else is getting care in the community. Now, that's not necessarily a bad thing, because community oncologists are also outstanding, compassionate, intelligent, and thorough doctors. The challenge comes in to something that's really unique in many cases to cancer care delivery today, in that the way cancer care is delivered at these subspecialty centers, at these centers of excellence, is in a subspecialist way. So in my practice at Duke, which is one of these centers, um, only treated patients with gastrointestinal cancers. So I only had to worry about GI cancers and the evidence that comes out every single day around these cancers. And, the new drugs that are approved, it feels like every single month around those cancers. I don't have to worry about what's happening with lung cancer or prostate cancer or breast cancer. That, incredibly intelligent and compassionate community oncologist
Mm,
treats every cancer. And they may go, a community oncologist might go into one room and treat a patient with breast cancer, and the next room with prostate, the next room with leukemia.
mm.
And that's a lot to keep up with. And we see that in how care is delivered, where, you know, guideline concordant care is only delivered about 60% of the time.
Wait, say that
That's where
again.
the gap,
Guideline concordant care is only delivered what percentage of the time?
60% of the time.
60% is. So 40% of the time, you're not getting the optimal, up to date
Yeah.
recommended treatment in cancer.
Right. And again, I
That's
want to be
profound.
very clear, like the reason that's happening is not because of bad doctors at all.
Right. Right.
It's actually because of one of the, it's actually because of the pace at which cancer care is evolving.
Hmm.
In 2025, there were 50 plus new indications of for cancer drugs per the FDA.
Mm.
50 new drugs and indications. How can you expect, one person
Right.
to keep up with all of that?
Right.
So I think that's a really unique challenge in cancer care delivery today. And
Mhm.
it's
Mhm.
that
Mm.
rapidly advancing pace of the science that's in some
Yeah.
ways actually contributing to the knowledge gap.
Yeah. It was interesting before you said, you as a gastrointestinal cancer specialist, you only have to worry about this. The beauty of being at one of these National Cancer Institute, designated comprehensive centers is that there are hundreds of others like you who are just as smart as you are, who spend their time focused on one thing. So when you go there, I get to see that specialist or sub specialist in that, and also I imagine the community that you actually could call on your colleagues pretty easily to get second opinions. And I have seen some of this literature about the second opinions. Mayo and other organizations have published that when they get second opinions in oncology, that there's a fairly significant percentage, and I'm not sure it's the majority or not. You may have this stat at your hand, but they actually turn the diagnosis and treatment around. They change it based on second or third opinions, which is to me frightening that it's such a high percentage. But I wonder if you have a thought about second opinions in cancer care.
I do. And I think that has to do with what I do for a living, which is really ensuring that that expert opinion that's, resides in that ivory tower that only a minority of patients have access to is democratized across the country for, whoever may need it. Look, I spent most of my career sort of delivering second opinions in my practice at Duke, where patients were coming to
Mm,
Duke for that second opinion. But for my own patients at Duke, I would often and very comfortably say, get a second opinion yourself, right?
mm,
The worst that it can do is say, well, yep, confirms the care. And what that does is provide more confidence in the care that you're getting. But maybe I learned something new.
mm.
Maybe I think, I get an opinion that I hadn't thought of, one minor difference in the treatment that could make a tremendous difference in the outcome. I think that's, again, really critical to the nature of practice of oncology today, where it has to be collaborative. And we have to think of second opinions not as questioning, um, but as a collaborative approach to care for the patient.
Yeah, no, I love that notion of collaborative approach. I do have to say the statistic you mentioned before that 80% of the American public does not have access to these pockets of care, these NCI comprehensive designated comprehensive cancer centers, 80%. So what what is the solution? How do you bring that sort of collaborative second opinion, really up to date care to the 80% that actually doesn't have access to it?
Well, I think there's three ways that it's happening to them. One is to move the patient, right? So patient travels to the center of excellence, travels back and forth from home, or
Mhm.
lives away from home for a period of time. That's not sustainable for everybody. Some people do that, right? Absolutely, people do that. But
Mhm.
that's not sustainable for everybody. It's an option. The other,
Well, can I say, Yusuf, can I just, not only is it not sustainable, I don't think it's affordable. The majority of Americans have $500 to $1,000 in the savings account. The idea of actually traveling across the country, two people, three people, putting yourself up at a hotel, for, 2, 3 nights. Some of these centers require you to be there for a week for the comprehensive assessment. I mean, how many people can afford to do that? And then if you want a third opinion, and et cetera. So I agree with you. It's not only is it not sustainable, I don't think it's affordable. I don't think it's practical for the majority of people.
It's not, and not to mention the time off work for the patient or the caregiver, right, to do all of that. The second option, and the second sort of approach that happens every day, is this ad hoc physician to physician consultation. So this happened to me often, right? I'm in clinic, I get a call on my phone from a community oncologist who says, look, I've got this patient with pancreatic cancer in my clinic, and it's this strange presentation. There's something unique about the case. What should I do next? And I say, oh, okay, well, you could think about A, B, or C. I provide that opinion. That oncologist then takes that opinion and implements it. But that's sort of ad hoc. They have to have the number of the subspecialist oncologist who then answers the phone and is able to make that connection. But those relationships are critical in oncology today, and absolutely that happens every day. The third is the approach that we're taking at AccessHope. And that is to say, let's formalize and make and sort of provide, a framework around that ad hoc experience that oncologists have without having to move the patient. And so what we do then is in a population, when we identify a patient with cancer or is receiving treatment for cancer, we're able to allow that patient, that their medical records to get reviewed by a subspecialist oncologist at one of our 7 NCI designated comprehensive cancer center partners. So if it's a patient with breast cancer, breast oncologist reviews their case, and then we deliver that expert opinion to the oncologist. So in a sense, it's a oncologist to oncologist consultation, but we're not putting the burden on the patient to opt in, because we know patients are not opting into second opinions at a very high rate in the US today. And so we remove that burden from the patient, we remove the burden of travel from the patient, and we sort of bring that expert opinion to wherever the patient's being treated.
Couple of questions. So this sounds like like you said, an oncologist to an oncologist. So question number one is, can primary care physicians access this, or does it have to be from an oncologist to AccessHope? Question number one. Question number two is, how is it paid for?
Yeah, great question. So, we've thought a lot about how a primary care doc might benefit from this service. Right now, we're oncology focused for sure, or I mean, oncologist focused. But, primary care docs are at the interface of pre-cancer and symptoms to cancer diagnosis, right? And the question remains is, can we help a primary care doc get to a cancer diagnosis sooner? And that's something we've been thinking of. But who pays for this, right? Because I think that's the ultimate question in healthcare is great idea, who pays? It's not the patient, and it's not the oncologist who receives it. We provide this service as an employee benefit. So our clients are, for the most part, large employers who say, we want to make sure that our members, our employees, have access to the best care possible. And by the way, can we do that without disrupting their doctor-patient relationship and without, sending them across the country? So that's when they look to us to provide this expert opinion service, remote expert opinion service, as an employee benefit.
That's fascinating. So you literally contract with employers, and
That's right.
so you're this is fascinating. So you're an oncology direct to employer business.
That's right.
Now, why would I, as an employer, I mean, HR directors, benefits managers within employers, even large ones, I mean, they're not clinicians, they're probably just thinking, they work through benefits brokers. So are you working through benefits brokers that are saying, hey, listen, I've got this oncology service that you should pay for? And is it a PMPM payment that they pay? Is per member per month or per employee per month? Or how does that work? I'm just really curious how you connect to employers. I mean, I can see direct primary care is big movement. even some of the specialties, so orthopedics, et cetera, we see these sort of, but we see what happens is we see individual cases going through middlemen who say, okay, listen, I can get you a hip surgery or knee surgery at 50% of the cost in one of the highest quality orthopedic centers in the country, or GI surgeries or cardiac procedures at the top places, that direct to employer, so-called centers of excellence, if you will. That's been going on for some time. I just looked at the National Alliance for Healthcare Purchaser Coalition, which represents 90 million working Americans and their families. And, they were saying that this direct to employer movement, at this point, 28% of companies in the country are now doing this. So this is a serious, serious movement. This is the first I've heard of oncology being involved in that. Very curious how an employer would even know to contract with you and how that payment works.
Yeah. So let's take a look at it from the perspective of the HR benefits manager that you mentioned, and maybe their CFO. So what the HR benefits manager, so what the CFO sees, right, is that cancer is their number one healthcare expense.
Mhm.
And it's for all the reasons that we talked a little bit about earlier, and that I'm sure you and your listeners know about, right? The drugs are expensive. It's multidisciplinary care. It happens over a long period of time. There's complications. There's
Mhm.
acute care utilization. So cancer is expensive. And they think, okay, what can we do about making sure that if we're spending a lot on cancer, it's the best care possible to ensure the
Mhm.
outcomes are best. Now let's take a look at it from the HR benefits manager who gets a call from one of their members, one of their employees who says, "Look, I've just gotten cancer. I don't know what to do. Am I getting the right care? Can you help me? How do I know I'm getting the best care possible? Oh, and no, there's no way that I can travel across country to go to X, Y, or Z center to
Mhm.
get my treatment there. My family's here, and I need to stay here."
Mhm.
So that's where we step in, right? And and we can say, all right, we have a way of linking your member with uh, with that expert opinion to really ensure that their care is
Mhm.
optimized. And it might be a tiny tweak, right? It might be, oh, change this imaging modality,
Mhm.
change this aspect of your supportive care regimen. Or it might be actually you need to be on a different
Mhm.
anti-cancer regimen. And we
Mhm.
see that entire spectrum. And from the perspective of the HR benefits manager, right, this is a solution that is scalable across their population. It
Mhm.
goes to the patient where they are in a rural community, far away from a center of excellence.
Mhm.
And critically, it doesn't interfere with the doctor-patient relationship. It lets that
Mhm.
sacrosanct relationships stay intact, and yet informs it. And so I'll give you an example of a case recently that we had
Mhm.
where there was a young patient with kidney cancer who was being
Mhm.
treated in a rural area, and we did a review on that patient, and the subspecialist oncologist at the NCI Comprehensive Cancer Center who looked at the case was a little bit concerned because they thought, well, this patient is clearly not on the right treatment.
Mhm.
So they wrote up the review. We sent it to the community oncologist who was treating that patient. And then we reached out to that oncologist and said, hey, look, we know this treatment plan looks a little bit different than what you're on now. Do you want to talk about it? Um, that oncologist said to us, you got me this review at just the right time because I wasn't sure what the next step
Mhm.
was in terms of standard of care therapy. And I
Mhm.
didn't realize this other option existed. Oh, and by the way, you also mentioned that there's a clinical trial that my
Mhm.
patient might be eligible for. I didn't know that was available either, relatively close to where the patient lived. And so that's the sort of benefit
Sure.
of what we do, and why employers who are seeing this, the statistics we talked about of,
Yes.
not a knowledge gap, inequities in care, inequities in access, and high cost, right? That's why they look
Mhm.
to it.
Yeah, and I think what we talked about before, the fact that cancer is affecting a younger and younger population, essentially it's affecting a working
Yeah.
age population as opposed to people who are in retirement. We're seeing now people who are in the prime of their work career. And so even intensifies the argument that employers should be would be not only concerned about this, but seeing the increasing costs. The medications are definitely increasing in costs. Yeah, it's. I didn't realize it was the number one cost. I knew it was probably in the top three or four, but I could understand that. I mean, to your point, it's not just the medical. It's not just the physician's costs. There's typically multiple physicians involved, multiple centers involved, and the drugs are incredibly expensive. And this could go on for. Often, this is not a, like you say, it becomes almost like a chronic disease at this point. So it's not a one and done sort of phenomena.
Yeah, exactly. I mean, this is the double-edged sword of scientific advancement in cancer care today. People are doing better, so they're on treatment for longer. I mean, you look at these new immunotherapies that are out, right? This is the sort of cutting edge in cancer care today, where we're harnessing the body's immune system to
Mm,
fight the cancer.
mm,
Patients are on these treatments now for years in many
mhm,
cases.
mm.
And these drugs are expensive, costing not just thousands, but sometimes, over $10,000 per month, per
Per
month,
month. Per
per
month.
month. And
Wow.
so these drugs are effective and expensive. And if they're not used appropriately, that's when you really start needing this intervention to ensure that
Mm.
we're getting the right drug to the right patient at the right time.
Yeah, this is really again super fascinating. I wasn't aware that you are. So do you, when you try to make this known, market this, are you going to benefits brokers? Are you going to HR managers at employers? Are you going to, like, for instance, the National Alliance, which represents coalitions of organizations and employers that purchase healthcare? Who are you going to speak to? Who would be interested in this, and how can they access this? Access Hope.
Yeah, absolutely. I mean, yes to all of the above. I think we are really fortunate to have, to serve over, I believe it's 800 clients now, and have, 10 million covered lives. And that's because of, as you said, the sort of unique way that we can really impact the quality of cancer care for a population.
We talk about so much about the problems in healthcare and focus on that. And I think stories like yours and Dr. Zafar and what you're doing with your colleagues at Access Hope and the seven NCI centers. And I just think it's just such a brilliant story of hope and super encouraging. And your passion and your humanity and your empathy are just so abundantly clear and resonant. So I just, just uplifting. I can't thank you enough. I hope people listen to this, and if there's anything I could do to help you get the word out there, I'm a big fan of yours now. And I think like many of us, cancer has affected me not only as a provider, and I would say it's for sure of all the illnesses and diseases, the toughest one from a provider point of view to deal with, not just intellectually, but I think emotionally. And so I think this is amazing work. Dr. Safar, what a unbelievable pleasure to meet you. And I hope we stay in touch.
I would love that, Zev. Thank you so much for the opportunity. Lovely discussion.
Thank you.